Thank you. Thank you. And so I'm Davin Chow. I want to thank you for inviting me. Thanks to Wei Tree and to the American Association of Chinese American Physicians. I'm glad to say that I had a role in Wei's career path, and so good to see him mature and grow over the course of his career. If you appreciate it, I did have a role in it. If you don't like him, then I had nothing to do with it. So I'm a primary care physician, and you may ask, why am I a primary care physician? Because I can't sing. I guess is this, press. Well, that's okay. I'll just do it here. All right. So I'm going to talk about primary care in general. I'm going to start with a story. Story of a patient. A gentleman had chest pain, and he had terrible chest pain. It was a funny kind of chest pain on the left side of his chest, near where his heart is. Had some tingling and radiation of the pain. And so he didn't know what to do. He went to see a cardiologist. And so what did the cardiologist do? The cardiologist said, you have chest pain. We need to evaluate that. He listened to his heart, and then he set him up for a stress test. He had a stress test. And they injected dye into his arm. He had the stress test, and fortunately the stress test was negative. So the cardiologist said, great, your heart is good. And the patient said, I still have the chest pain. And the cardiologist said, well, it's not the heart. You're in good shape. So, and the cardiologist said, maybe it's GI. It could be GI. So the patient goes to see a gastroenterologist. And gastroenterologist listens to his story, strikes his chin, and says, I don't think for sure this is GI, but here, I will prescribe some proton pump inhibitor, see if this helps you. So he took the proton pump inhibitor for a couple days. It did not help. So then what happened? The patient went to see a primary care doctor, and the primary care doctor examined him. And what did he find? It's hard to see. But on the side of this, on the flank, he had a rash, a vesicular rash. So what did he have? Shingles. So this is, and I'm trying to say the story because there's a role for primary care, and the role of primary care is a very important one here in the U.S. We have wonderful subspecialists who practice state-of-the-art medicine, but the primary care physicians in this country still play an important role. What is the role of primary care? And I'll run through this quickly. Hopefully the first point of contact. They provide continuity over time, comprehensive primary care, concern for the entire patient rather than organization system-based approach. They coordinate care with other touch points in the healthcare system. Well, now they're also somewhat responsible for trying to computerize and organize the patient's information into one database. And try to focus on preventative medicine and health maintenance. So it's a little bit like if your health is like your car, it's like going to Jiffy Lube. Right? You have to do maintenance on your car. But I don't quite like that analogy. Nonetheless, this week my car was in the shop, and I just got it back yesterday. And the shop director said, the garage mechanic said, it's going to cost a lot of money when he took my car. And I said, why is it going to cost so much money? It's just brakes. He said, oh, labor. So I said, oh, how much is labor? He says, we charge $100 an hour. Now, I'm also a hospitalist director. You know how much we pay our hospitalists? We pay them $90 an hour for moonlighting. So those of you who are medical students in the audience, this There's a lesson here. All right, so who is providing primary care in the U.S. now? And maybe difficult to see, but there's 80,000 family practice physicians who are practicing, 3,000 geriatricians. There's about 10,000 folks who are in general practice. And then general internal medicine is about 70,000. And in peds, there's about 45,000. Now, so altogether, there's about 200,000 primary care physicians in the U.S. A growing population, however, is the population of nurse practitioners and physician assistants. That population is growing exponentially, and there's no stopping, meaning that it's continuing to escalate. And that may be a trend. Is primary care good for your health? Well, it's been shown that every additional primary care physician per 10,000 patients in a population is linked to 5% decrease in mortality rate of that population. A decrease of this magnitude would mean 139,000 fewer deaths per year. Higher numbers of primary care doctors and community associated with a range of improved health outcomes for that population, including longer health expectancy, healthier newborns, lower death rates of cancer, heart disease, stroke, and infant mortality. Also, primary care physicians reduce the cost of healthcare. As you know, we're going through a crisis in healthcare expenditures in this country. Why is there a crisis in primary care? Well, we have 65 million patients who are experiencing primary care shortages in the U.S. Now, primary care shortage is occurring in certain areas of the country and then not occurring in other areas. There's not a primary care shortage in Beverly Hills, but in the Midwest, there are multiple communities that don't have primary care physicians. One of my residents just took a job as a primary care doctor in Eastern Shore. That community was so happy to have her. Up until then, they did not have a primary care doctor. They had nurse practitioners. And those were the people who were seeing the patients in that community. By 2020, there'll be a shortage of about 90,000 primary care doctors in the U.S. And so why are we experiencing this shortage? And the health system that you get in any country is a health system that you pay for. It's a health system that incentives are aligned for. And our health system here in the U.S. is aligned towards rewarding procedures that treat disease rather than interventions that prevent disease. So as a primary care doctor, I spend a lot of time trying to counsel my patients to stop smoking. And it takes a lot of time. Does Medicare reimburse for that? Minimally. However, if they continue to smoke and they end up having a heart attack, that cardiologist who throws a little metal piece of hardware into the patient's heart for 20 minutes will get thousands of dollars. This is how our system is set up, and so our incentives are aligned in that way. And so the health system that we get is a health system that the system is incentivized for. There's a lack of incentives that reward preventive care and disease prevention, and incentives reward high volume. So when you go to a primary care doctor, how long do they have to see you? About 15 minutes, right? On a good day. And half that time they're sitting there typing on their chart, right? But this is what has evolved. The more patients that they can see, the greater the throughput, and that's how their incentives are aligned. But that doesn't have to be that way. I was fortunate to be a guest of teaching in Japan. In Japan, they have a socialized health system And it's a complicated reimbursement process for physicians. But essentially, to a large degree, you're reimbursed based on seniority, how many years you're out of medical school, irrespective of what your specialty is. Cardiologist, gastroenterologist, cardiac surgeon, or general internist. So you know what, I went there as a visiting professor, and they said to me, oh, Dr. Chow, what specialty do you practice? And I said, oh, gosh, I'm just a general internist. You know what they said? Sensei. Because they're the most highly respected providers in the Japanese system. All the patients come through the primary care, through a general internist, and then they'll get funneled to specialists. And the general internist is the one who makes the diagnostic decisions, and then they'll ask their specialist colleagues for help with the technical aspects of the case. So they command a great deal of respect, which was quite a novel experience for me. Then this year I had a chance to go to Taiwan as a visiting teacher there, and they said to me, Dr. Chow, what kind of specialist are you? I said, oh, I'm just a general internist. And they said, oh, Dr. Chow, you seem like a smart guy. Why are you just a general internist? So the system that you get is a system that you set up your incentive programs to align for. Now, there's a crisis in primary care with the ones who, not only do we have a lack of providers providing primary care, those who are providing primary care are stressed out. Have you gone to your primary care doctor and you seem to get the sense that they're stressed out? They're working very hard, and part of it is the electronic medical record, part of it is the paperwork. If you, a very efficient primary care doctor's office now, their overhead is about 60%. It's about 60%, right? And back in my day, before electronic medical record and prior authorizations, the overhead was around 30 to 40%. So if you go to a primary care doctor, they're accountable to hire a specialist just to do referrals, a specialist to do billing and coding. This adds to the cost, and this makes the primary care doctor feel like they got to work more, see more patients in order to generate enough revenue in order to pay the overhead. So how are primary care doctors reacting? Well, 57% of primary care doctors are now were in independent practice. Now it's 33% in 2016. What's happened is they've given up private practice and they've joined large organizations like a hospital, or they joined a large organization that has combined private practices together under a big umbrella. And why have they done that? To achieve some economies of scale, so that 10 doctors can share one billing person. They can share the electronic medical record costs. And so what's happened is that the autonomy that a solo or a small private practice had in the past, that's been lost. Although there's still some dinosaurs, like my friend Ray, right? And so there's a migration of independent practices into organized healthcare systems. Back years ago, not that long ago, almost every doctor accepted Medicare. That's how he got paid. Now, 73% of primary care physicians accept Medicare. That means that a quarter of the primary care doctors out there are saying, we don't accept Medicare. If you want to come see me, put cash on the barrel. Medicare it's a headache, and it might get worse. So one approach that primary care doctors have taken is this concierge medicine approach, or they call it direct primary care model. I imagine there's some of this here in Montgomery County. Is that true? No. Yeah, we have in certain areas of Baltimore where I'm from. There's certain suburbs which you can't So what's happened is, what concierge medicine is this? I'm a primary care doctor. I'm going to limit my practice to 300 patients. I'm only going to have 300 patients. Those 300 patients have to pay me an amount of money every year for the privilege of being in that panel. And that amount will vary from doctor to doctor. Maybe $1,500 a year. It may be $2,000 a year. But whatever that cost is, whatever that amount is, it goes in my pocket. And it helps me to pay my office and pay my bills. And then in addition, whenever you come see me, I will charge billing insurance. But why do you want to do that? Because when you pay this amount of money, you now have the privilege of having access. If I only have 300 patients, I should be able to fit you in the same day if you have a medical issue. I should be able to call you back that afternoon if you call me in the morning. This access is what you're paying for. I'm not supporting this because what's happened is that those patients who cannot pay or don't want to pay are being alienated. So in my community, in which many doctors have gone concierge, those doctors who are not are being inundated, being flooded with calls for patients who want to get a new primary care doctor because they're all one concierge. And so there's a discordance of care in the community, those who are in concierge medicine, those who are not. I was talking to my friend who practices in Florida, and it's almost a sort of it's like having a Lexus in your garage. I have a concierge doctor. It's like a status symbol, and it's something that everyone aspires to have. Now, I don't know what the future of primary care is going to be. It's hard for me to read the tea leaves. Is this concierge model going to rule the day? And I hope not. I hope not, because that shouldn't be how the public receives care. What primary care doctors are saying, though, by signing up for concierge medicine, is that they feel like they're not getting reimbursed for the extra work that they do, the work they spend, time they spend with electronic medical record, time they're doing paperwork, filling out forms, getting prior authorization, those currently unreimbursed tasks. That's what they feel like this extra charge is being used for. So Medicare is trying to help by emphasizing a new way of reimbursement based on value, value-based care. And this is going into effect now. And next year, it'll be up and running with folks in practice, and you can choose whether you want to be reimbursed based on value or reimbursed based on volume. And there are penalties for not signing up for the value-based care. So what does that mean? And this is one of the problems I have with this. How do you measure value? How do you measure quality in primary care? Well, how's Medicare going to measure it? You're going to ask your patients. They're going to ask your patients. And I've seen the questionnaire. It's a 60-item questionnaire. These patients are going to have dementia going through this questionnaire. They're going to ask, did your doctor ask you about domestic violence during the visit? Did your doctor ask about the level of pain? Did they ask you, and there's 60 of these questions, and I'd be darned if I could remember all of the things that a doctor would do with you during the course of the visit, but they ask for all these items. And apparently if you do hit on all these items, then you'll be viewed as a high-quality physician. Now, if you spend all your time during a visit asking about domestic violence and all these other issues, you may not be able to attend to the patient's purpose for coming to the visit. So there's a challenge here. Primary care is going to be more team-based. That means when you go to the primary care doctor's office, there may be a social worker, there may be a nurse manager, a psychiatry person. So it's not going to be just a MD who will be participating in your care. It'll be more multidisciplinary. And why is that? Because A, that's a need of our population. But it's a way to help diffuse some of the needs, some of the pressures that fall on the shoulders of the primary care doctor and spread it out to those people who are more trained to do those kinds of tasks, attend to those kinds of needs. So this is, and I'm not an expert on MACRA, which is the Medicare Access and CHIP Reauthorization Act, but this is the program that Medicare is putting in place. It's going to, people can enroll in it now, and then there's training that's occurring now, and then 2018 it will be up and running. And this is the program in which physicians will be reimbursed based on value metrics. And you and I can complain about the metrics and challenge them, but this is how things will go forward. And this is probably just the first step, and there are probably going to be additional and more complex methodologies and evaluating quality as we go forward. The interest is to try to reimburse quality rather than just reimburse based on volume. Okay, so I want to summarize just by, again, giving you another story. So this is a story of a patient who was in her usual health, and one of the things that is available to patients who smoke and fit a certain age group is you get a screening CAT scan to check for lung cancer. It's a way of putting radiologists' children through college. No, that's not true. Pardon my cynicism. Unfortunately, the patient had a lung mass. Now, she was asymptomatic, but she had a lung mass. And she was a non-smoker. She had smoked, but now she's had stopped. And so what happened? Then, of course, she had to go to a specialist, got a biopsy confirmed adenocarcinoma. She went to go through a process called staging and trying to figure out whether the disease had spread. And indeed, unfortunately, it had spread to the mediastinum, and she was deemed not a candidate for radiation therapy. So she went to a important, well-claimed medical center, which I won't name, but she went there, saw a specialist, a thoracic specialist, an oncologist, and the oncologist was young, very energetic, but very eager, and tried to give her some chemotherapy. She got chemotherapy for about 3 months, and she tolerated the chemotherapy well, but the disease had spread, and so they declared the chemotherapy not effective. And then they switched her to another treatment regimen. She came back to me, and she said, Dr. Chow, these doctors at this medical center, they're very nice doctors, they're well-meaning, but I'm not going back. And I said, why? And she said, they don't listen to me. They don't examine me. They look at, when I sit with them, they look at my laboratory test, they look at my blood count, they look at my liver test, they do x-rays, they do CAT scans, they do MRIs, and then they talk to each other. There's a fellow, there's an attending, there's a nurse, and then they give her papers when she leaves the office. And she said, I don't know if I want to go through more of this stuff. So I said, what do you want to do? And she said, well, I want to visit my family. So she went to, I said, where's your family? Your family's in China. So I said, get a ticket, go visit your family. So she did, and she came back, and she passed away. But I think she passed away living her life. And I think that's the role of primary care. It's a role where we embrace our relationships, we embrace the person, and we're not treating the cancer, we're treating the person. And that's, I think, ultimately That's why primary care is going to survive, it's going to live, it's going to thrive. My brother, who's a information technologist, he's an IT guy, and he's always said, they can build a computer to do what we do. Computers can Watson can diagnose diseases much better than I can diagnose diseases. And that's for sure, that's probably true. But computers can't do this stuff. And this is why you all went to medicine. And this is the beauty, I think, of what primary care is all about. So thank you very much.
Thank you.